Good morning. I'm Oliver Monfredi with Heart Rhythm TV, and I'm delighted to be here with Enrico Ferro from Beth Israel.
Right.
Great to meet you. I know you've got a fantastic abstract that you're presenting at the meeting today. Can you tell us more about that, Enrico?
Absolutely. Thanks for having us, and thanks for your interest in our work.
Yes, sir.
So in our study, we studied about 25,000 tricuspid valve procedures done in the United States among Medicare patients from 2016 to 2023. Of those, we found that about 10% had a pre-existing pacemaker or defibrillator lead. And so I would say that's the first important finding from our study, is defining the size of a problem. We all know that since 2024, there has been an exponential increase in data and adoption of percutaneous valve procedures and replacement for the tricuspid valve. We want to know, how should these patients with pre-existing leads be managed? Should you jail the lead? Should you extract the lead? Both are not risk-free propositions. Right? So 10% is a sizable minority, and it tracks with the trials. As you may know from the Triluminate and the Trisend, about 15 to 40% of patients have leads. 10% here, maybe it's on the lower end of the spectrum, but this is a real-world nationwide population.
Absolutely.
And notably, these patients are sicker than the other patients who are undergoing tricuspid valve procedures. They are older, they have more heart failure, more ischemic heart disease, which is no surprise. There is a reason they have a device to begin with, that CRT, that ICD. So it's important to develop tailored guidance. So in the next step of our study, we looked at temporal trends. What is happening in the volume and in the market of tricuspid procedure? I'll tell you, starting in 2016, about 80% were surgical procedures, as expected. However, the surgical volume has been decreasing at about 5% per year, whereas percutaneous volume is coming up from 20%, rising at 5% per year. Some of it predates the dedicated tricuspid technology, so it was probably off-label use of mitral and aortic devices. Nonetheless, they're being used. And notably, and this is relevant again for the device population, patients with pre-existing devices are about twice as likely to undergo percutaneous procedures for the tricuspid valve repair and replacement. So they're going to be driving the market, we think. That's why it's so important to know about them.
Absolutely.
So next, we looked at how often is lead extraction performed. About 20% of these patients with devices undergo a lead extraction at the time of a valve intervention. And so we asked, what are the predictors? Which patients are being selected for the extraction? We found that patients who are older and with more comorbidities are less likely to be extracted.
Makes sense.
Not surprisingly.
Yep.
Patients with longer lead dwell time and patients with leadless devices are also less likely to be extracted. Longer dwell time, higher risk extraction. Leadless devices, we think perhaps less interaction with the tricuspid system. But most importantly, we found the key predictor of extraction was having a clinical indication for extraction at the time of intervention. What I mean is about 35% of patients had endocarditis, 15% had a lead malfunction, and a minority with lead-related venous obstruction and so on. So that's important. It's telling us that today, operators are really thinking carefully about who gets an extraction and who doesn't. And that's important.
Sure.
And lastly, I would say we looked at the elephant in the room. What are the outcomes? What happens if at the time of a valve intervention you also extract the lead, or if you just do a tricuspid valve intervention? These are all risk adjusted, and we found that there is no significant difference in in-hospital or 30-day outcomes if you extract the lead at the time of tricuspid valve intervention. Notably, however, we need to look at the absolute event rates. We know these are sick patients, the ones undergoing tricuspid valve intervention. So we found a 1% in hospital death, about a 10% major bleeding requiring transfusion. These across all tricuspid procedure. Again, sick patients, but reassuringly adding on the lead extraction does not meaningfully increase complications. So I think these are the key findings from our study.
Excellent. And if there was one unique finding from your study, what would you say that was?
Great point. Yes, I would say, first of all, the generalizability. I mean, we have trial data, but I think at our Smith Center for Outcomes Research, we really are interested in real world. So when these procedures are done across the US, across hospitals and operators with very heterogeneous level of experience and exposure to the procedures. I think that adds to the literature in really giving broad, generalizable findings. And I think I've actually been following some of your prior interviews on the topic, and most of the experts on lead extraction are saying really have no data. We have anecdotes, we have case reports, but this is now looking at 2,500 patients with devices, which is giving us a lot of data, hopefully, to reassure providers and patients that as long as the procedure is clinically indicated, meaning the extraction, we should be reassured that it can be performed.
Excellent. And it seems likely that these kinds of procedures, percutaneous tricuspid valve procedures, are just going to grow exponentially over time.
Right.
You know, where do your results, where are they going to put us in sort of 5 to 10 years' time? Where do you think we're going to be as a field, you know, in 5 to 10 years' time? Are we going to abandon any leads, or are we going to accept that some leads have to be jailed, or are we going to be in a situation where we're going to have strong recommendations, do you think, to extract these leads?
Right, absolutely. That's a key question that I think the field, both from the structural perspective, the EP perspective, the heart failure perspective, everyone wants to know what should we do. So I think what we did today is step one. We are establishing a benchmark in terms of what are the event rates, what are the complication rates. I think definitely, as you're saying, dedicated percutaneous tricuspid procedures are here to stay, are here to grow, and our platform is ready as soon as the data starts rolling in. That's another unique beauty of Medicare claims, is that we're ready to keep tracking the market and practice patterns. So I think the next step in probably less than 5 years is going to be what happens now as the percutaneous procedures take over the tricuspid space. And one may think, well, is that similarly applicable to repair and replacement? Certainly the jailing is obvious in the case of replacement, but even with repair, there is concerns about damaging the lead by interaction between the clip and the lead. So really it's a platform that's going to give us a lot of information. But I would tell you that that's part one of our study. We're now in the process of launching part two, because so far we talked about should you extract the lead?
Right.
Well, what happens if you jail? And we are now going to connect very granular patient-level device data from manufacturers with Medicare claims, and now we can get the granularity to say what happens to lead impedance, what happens to the pacing thresholds after you jail,
right.
Which is, I think, the other side and equally important half of the question.
Absolutely. I think your work's fantastic. I think that it's so needed and important in terms of like our ability to better understand how to handle device patients with this burgeoning field of tricuspid valve repair and replacement, and I thank you for doing it. Enrico, thanks for joining me today.
Absolutely. Thanks for having me. Thank you, everyone.